Hello, everyone. I'm Leslie Verner with Carolina Breast Friends, and I am so happy to have you with us today. Aleece Fosnight is a friend of mine from Asheville. We work together, and I am really excited about sharing her with you all today. She is amazing at what she does, and I think you will learn a lot. She is a board-certified physician assistant specializing in sexual medicine. She is the founder, owner, and director of the Fosnight Center for Sexual Health in Asheville, and they just celebrated their first year anniversary. And as many of you heard, they're already talking about expanding. She specializes in all areas of sexual health, and in particular for our group, effects of cancer and cancer treatment on sexuality, menopause, and pelvic floor dysfunction. Aleece, it is so wonderful to have you with us today.
Well, and I am just so honored, Leslie, to be here. Anytime that I have an opportunity to talk about sex and sexuality and body image and loving yourself and finding pleasure, I mean, those are definitely my key things, and those are rooted in one of the reasons why I opened up my own practice. So hello, everybody. Again, my name is Aleece Fosnight. Thank you for that lovely introduction, Leslie. As you can see, from our slide up here, that there are the alphabet soup behind my name. And so I am a board certified physician assistant. I am celebrating 10 years. So I'm in double digits now of being a PA. I went to the University of Kentucky for PA school. This little PAC just means that I have passed my boards and I'm certified and I'm up to date with all my stuff. These two little letters over here are the two initials. So what this is, I'm a certified sexuality counselor supervisor, and I'm a certified sexuality educator. So I went on to the University of Michigan for a postgraduate certificate in sex counseling and education. I quickly realized getting into practice that I wanted more. So where did my journey kind of start with sexuality, and how did I get into sexual medicine? I always love this story and love sharing it. So we were in the middle of PA school, and at the end of our kind of clinical year, getting ready, or excuse me, didactic year, getting ready to get it into our clinical year, and we were all finishing up our master's thesis and being able to present our projects. And all of my classmates were doing blood pressure, diabetes, orthopedics. And although that is very important, it doesn't give me a lot of passion. And so trying to come up with what I wanted to do, I knew quickly after starting PA school that I loved women's health. And that was kind of my main focus. So I was looking for different topics on the gynecology route for women's health. I happened to be on the phone with my mom when I was watching TV, and a Viagra commercial came on the television. And I thought, oh my gosh, Mom, if there is a blue pill for men, there has got to be a pink pill out there for women. And at that time, 12 years ago, almost 13 years ago, there was nothing. And I got super pissed off. I was like, this is not okay. I don't love this. We've got to figure out what else is going on. And so I did my master's thesis on female sexual dysfunction. When I was doing all of my articles and research, they were coming from urology journals. So here I thought sexual medicine actually fell under OBGYN, and then it fell under urology for men. That was not the case. Sexual medicine actually fell under urology. So with that being said, I did a whole bunch of gynecology rotations. I did a urogynecology rotation over in England and had an amazing experience at a sexual medicine clinic over there, and just knew that this was for me. This is what I really wanted to do. So I actually got a call from a urologist back in my hometown in Brevard, who I had worked with when I was in high school, that said, hey, I want you to come back home. I want you to do female urology and female sexual medicine. What? My dream job? Right out of school? This doesn't ever happen. So my husband and I at the time said, we got to jump on this. This is what I really want to do. And so we picked up our house and moved back home. And it's been the best ever since. But I recognized very quickly that I was not equipped to be able to have these conversations, and that most medical people are not equipped, and we don't have conversations about sex and sexuality. So I get that for me, this is a really easy topic. I talk about it every day, all the time. I have 3 beautiful little girls, 6, 4, and 2, and I still talk about it with them, but it's on their level, right? They know what parts and pieces pieces are, they know what their body is, they know about consent, and that people have to ask permission to, give them hugs and whatever else. So, I really wanted to bring more awareness to this topic, and that it is really important for us as whole individuals to be looking at the mind, body, spirit, and that sex and intimacy is definitely something that we want to embrace, and it's part of who we are. And that the crappy piece of it is that things that happen in life, like a breast cancer diagnosis or a prostate cancer diagnosis, or the fact that we have had children and our bellies are stretched out and it's body image, or all of these things that are happening in our lives definitely impact our relationships with ourselves, relationships with our partners, and the intimacy that we have within that space. So I want to go ahead and get started. So I gave you a little bit of information already about me. I am the founder, director, CEO, all of the thingies for the Fosnight Center for Sexual Health. Again, we didn't have anything like this here in Western North Carolina. I actually had broached this topic with my healthcare system. And I said, oh my gosh, we should totally do this, have a comprehensive sexual medicine center, because I didn't tell you that at the time when I started with the urologist, his patients were 85% men and 15% women. So I had to learn to love those penises and prostates as well. But it was a really good opportunity for me to have a conversation with my male patients to say, what's going on with your wife? If you're here for Viagra, and we're going to help to create erections, are you doing this for yourself? Are you doing this for your partner? And if this is for partnered play, how does your partner function? Does your partner know that you're here? So I got to do it a little bit of a roundabout way of being able to bring more awareness about women and sexual health through my male patients. And of course, I still see them. I actually have a big trans non-binary population that I see also. And when, again, I broached this topic to my health system, unfortunately, they did not see the value in it. And I said, okay, you don't want to do it, I will do it. That's been my motto my whole entire life, that you tell me I can't, I will show you that I will. So here we are a year later, and we have the Fosnight Center for Sexual Health. Like I said, it's been absolutely amazing journey and an adventure. We were still learning. I have myself in the practice that is the medical provider, and then I have a pelvic floor physical therapist, and then I have two sex therapists, mental health therapists, so that we can be more inclusive and have what we call a biopsychosocial model to taking care of sexual health concerns. We'll talk about that here in just a little bit. I do want to remind you all too, I want this to be really interactive. And so please, by all means, feel free to use the chat. I'm going to pull the chat. I thought I pulled the chat up. And oh, there it is. Okay, I just got to rearrange here just a second, because I want to see all of your beautiful faces as well. I have like 8 screens up going right now. So I want to make sure that I've got everybody. So feel free to use that chat box. You can send me a private message if you've got a specific question. If I feel like it's relevant to what we're talking about right here, I probably will go ahead and bring it up to the group. But feel free to take yourself off of mute and say, Aleece, I got a question. And I'm happy to talk about it right then and there. Okay. All right. So I know that these statistics are probably all very familiar to you all. We know that here in the United States that 1 in 8 women will develop breast cancer at some point in their lifetime, and that's huge. So, but we will develop it, but we really want to make sure that what are we looking at on the survival side of things, right? Because the survival rate for breast cancer with the treatment options that we have is really much higher than what we have seen even 10 or 15 years ago. So, right, we know our 5-year survival rate for women with non-metastatic invasive breast cancer is around 90%. So that 10-year survival rate is 84%. And if that breast cancer is located just in the breast by itself, then that survival at 5 years is 99%. But what's happening is now that you're dealing with all of those after effects from those treatments. And what I hear a lot from the oncologist is, well, we surgically helped you, we chemically helped you with medications. Oh, go live your life. You're alive. But quality of life is really important too. I know that quantity is really something we need to consider also. But if it's going to suck, we've got to think about what is it though we can make better, and what can we actually improve. So with the survival rates being pretty high, we know again that the after effects and the aftermath of those breast cancer treatments can be pretty devastating. So let's talk about it. We're going to jump right into the conversation. And right, I pose that question all the time. Why? Why are we talking about it? And because it really is important, and it is really important to your overall health. When we think about who you are and how you identify, right? It's so the sex that you were assigned at birth, it's the gender, which is how you identify yourself, your different orientations to who you love, who you're romantically attracted to, who do you want to share your body with. It can definitely include a lot of pleasure. So one of the things that we forget to talk about a lot of times when it comes to sex and intimacy is the pleasure piece of it. You know, we ask, do you have pain? Are you happy? You know, all those things, but pleasure is so important and should be the core of those things that we're talking about. When I was trying to come up with kind of my little motto, my little tagline for the Fosnight Center, again, it's this biopsychosocial, the mental piece of it, the body piece of it, but that's the pleasure piece of it. So my little tagline is to restore your mind, empower your body, and optimize pleasure. Because, right, we should enjoy pleasure with everything in life when it comes to, again, our bodies, who we're sharing our bodies with, and that relationship that we have with our partner. And again, we're talking about the quality of life piece of it. Okay, you're alive, this is great, you know, but now, again, you have all of those effects from those cancer treatments. And that's just like we talked about, it affects both the sexuality and the sexual functioning. So we have the World Health Organization's sexual health definition here. This is from 2006, and they have not updated it. I'm hoping that maybe someday they will, although it is a fabulous definition. I typically don't read from my slides, but I want to read you this definition. So the World Health Organization states that sexual health is a state of physical, emotional, mental, and social well-being related to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. So it's beautiful. So maybe they don't need to change it. So, you know, I love that definition, and I'm very sad to say that this was not a definition that we learned in PA school, nor do I know that they have this definition in medical schools as well. So again, these are topics of conversation that we should be talking about because again, we know how important they are. Here in the United States, there have been lots of cultural and social seeds that have been placed in our brains, right? So when we hear the word sex, what comes to your mind? Does anybody want to share? So when I say sex, you can put it in the chat. You can take yourself off mute. What do we normally think of when you hear the word sex? Right? We think like penis and vagina intercourse. Like that comes to our mind when somebody says sex. But we know that it's so much more than that, right? That's just the tip of the iceberg. You know, what if you don't have a partner? What if we're talking about solo sex, masturbation, self-pleasure, right? All of those types of things. What, you know, if we have multiple partners, you know, and what if our partner isn't a penis owner? Or what if they're not a vulva owner? So it's having those conversations of what does sex mean to you? And sex, you know, and sexual health, right, should be more of an umbrella term that encompasses all of those things and how we view ourselves and you view your body. Yes, Rebecca, right, it's intimacy. You know, when I bring that, you know, question up to a lot of my patients, again, they often say, well, sex is intercourse, right? But again, it's much more than that, and you know, a lot. But unfortunately, we're not programmed to think like that, or taught like that, or encouraged to think like that too. And again, with these hierarchies of what is the default, right? The default is in penis and vagina sex. And if you're not having penis and vagina sex, then something must be wrong with you, or something's going on. And again, that's not always the case. Okay, so we're going to talk a little bit about the sexual response cycle, because this will, oh yeah, Juliana, that's definitely right too. It's different meanings for both men and women. Yes, we'll talk a little bit about kind of the differences here in just a little bit too. But yes, you are totally right. And a lot of that too is what they have been taught. right? With the patriarchy and, their male roles and things like that, showing emotion or having a connection sometimes isn't always there. And there can be a lot of detachment from their partner too. They don't know how to respond to their partner when they're trying to be intimate or have that connection. So those are the things that we can work on together as well, and what I do as a counselor. So I get that question all the time too. What do you mean you're a sex counselor? How does that work? So as a medical professional, having the extra training to be able to have more in-depth conversations with individuals about their sexual response cycle, what turns them on, what turns them off, if they've had any negative sexual experiences in their lives. I get to have a conversation about what their parts and pieces are. Some people don't know where their clitoris is, right? So I get to be able to do all of those education and again, go a little bit more beyond that 10 or 15 minute office visit where it's in and out and I'll talk to you later and see you in 6 months, right? I get to have a little bit more in-depth conversation with my patients, which is great. So here's our sexual response cycle. This was all originated from our two sex researchers, William Masters and Virginia Johnson, back in the 1960s and into the 70s. William Masters was actually an OBGYN resident, and he was on his OBGYN rotation at the time when he saw his first vaginal delivery, and it was a little baby boy and had an erection during the time of birth. And he thought, well, this is very interesting. Babies don't have erections. They don't understand what that means. And so he asked his attending and said, what is up with this? Oh, it's the pressure coming through the vaginal canal that made that happen. Okay, he bought it. So then a couple weeks later, he was assisting with a C-section. And another baby boy was born that had an erection too. And he thought, well, they didn't come from the birth canal. What was happening? So again, he asked his attending and said, oh, it kind of blew him off and said, don't worry about it. It's just a spontaneous thing that happens. But it really got him curious more about the functionality of genitals and what actually is happening. And so back then, right, if you're going to do research on sex, you got to have a male and a female partner. So his secretary was Virginia Johnson. And so he reached out to her and said, hey, I've got this idea. Do you want to do some research with me? So they actually hired prostitutes. They watched over 10,000 encounters, right, to be able to actually come up with the sexual response cycle to say, okay, what is happening before intimacy, before sex happens, what's happening during that process, what happens during orgasm, and then resolution. So, right, we have our desire, which is rooted in sometimes this animalistic, this biology, fire in our bellies, right, attraction to somebody else. Then what happens is we start to partner up with that person, and we start to have a little bit of arousal, meaning that this could be an erection for a man. This could be clitoral engorgement for those that are vulva owners. You may notice some more like sweating. The heartbeat starts to go a little bit more. So that kind of parasympathetic and sympathetic nervous system start to kick into gear. And then you reach a threshold, which is that plateau, and that's where orgasm can actually happen. And as much fun as it would be to stay in orgasmic bliss 24/7, we actually have to get things done in the world. So we have to come down from orgasm, and that's that resolution time frame. So this is what they developed over that time. And that stayed in effect for almost 50 years until Rosemary Basson actually came into the playing field and said, I don't think so. I don't think that this is actually the same thing, very linear, that we're seeing here to the left as it is for women. That women don't always have this desire piece first. And so maybe they have some arousal first, or maybe they're at the sink doing dishes and their partner comes up behind them and they respond to that. Oh, and then they get turned on. So she said, this is more cyclical. This is more kind of roundabout, that sometimes you can possibly have spontaneous desire here, but it's not always the case. And that it can kind of come in here at any time, right? You can have an emotional connection. You can have a really amazing, in-depth, rich conversation with your partner, and that's the turn on, right? It's not necessarily that they're hair is slicked back and they're in their really nice outfit or whatever else. It could be more of an intelligent kind of desire that you have with that person. So again, realizing that there's a lot more to this than just step by step by step, up and down, and going through that. Now, do some women have this linear? Absolutely. And things can change. Then we have Emily Nagowski that came into the field, gosh, a couple of years ago. I do have a recommendation of her book, which is fantastic. It's Come As You Are. I have it listed in the resources at the end of this presentation. So she actually came out with this book, I think in 2017, 2018. She is a sex educator. And because low desire is the #1 sexual dysfunction among women, she said, I need to write a book about this. So it's actually 2015 is when she wrote the book. And so she said, we need to dig a little bit more deeper into what's going on with women's desire. And so this is what she kind of come up with. So we see, again, spontaneous, right? You could have sex and intimacy at the drop of a hat, right? Nothing has to be like, the house could be a mess, the kids are running around, but you're ready to have sex at that moment. Or it's responsive. So remember we talked about you're standing there at the kitchen sink, you're washing dishes, the partner comes up next to you, starts to kiss you on your neck, and then you get turned on, right? You're responding to those cues. So because again, men sometimes are the default, and men most of the time fall into the spontaneous category. Probably about 70% of the time, men fall into that category. About 15% of the time, women fall into the spontaneous category, right? There's a lot of other things that are going on. We're managing the household. We got to think about dinner. I got to go to work. What are the kids doing? What are my parents doing? If you're having to take care of your parents, it's all of those things, right? It's not necessarily in the forefront of our brain. So about 35% of women fall into that responsive desire. So you're thinking, Aleece, okay, where's this other 50%? The other 50% of women fall kind of in here. They can go back and forth. Sometimes they schedule intimacy. And so is that really spontaneous? Is that responsive, right? So it can be a blend of that. But this is one of the biggest things that I love to talk to my patients about, because they think something is wrong with them. If they don't want sex right away, that what's wrong with me? What is going on? Why is this? It's just because you're you, and that those cues, you don't necessarily have those cues, and there's nothing wrong with that. We just got to figure out what will turn you on, or what your turnoffs are, so we can turn off the offs, and figure out what can get you actually in the mood. And so again, by talking about like responsive, these are both okay responses to desire. You don't necessarily have to be in one or the other buckets, but knowing that it's okay to be in the responsive piece. And this is where I get a lot of frustration from the partners, right? They don't initiate anymore. I want them to initiate. Why are they don't find me attractive? They're not initiating. You initiated, before we had kids or before we got married. Why are you not initiating now? And things were a little bit different before maybe they got married or before they had kids, right? A lot of times you were dating and you planned for that event to happen. And so it seemed spontaneous, but you were prepping. They called you up on a Tuesday and said, hey, what are you doing this weekend? Nothing. What do you want to do? You want to go to the movies? You want to go to dinner? And so, yeah, I want to go do that. And so you're thinking during that whole time, right? Am I going to get naked? Are we going to kiss? Are we going to touch? Is sex going to happen? What's going on? So that's foreplay, right? Your brain is thinking about all those types of things. So now you got to shave your legs or shave your armpits or note, or, thinking about what outfits you're going to wear, right? You're planning for all of this to happen. And if it happens, awesome. But if it doesn't, then again, nobody's like disappointed because there wasn't necessarily some of an expectation. It wasn't said that it was, but it's spontaneous. People think it's spontaneous when it was actually planned. So again, having those conversations and just helping to refocus on what that goal is, and having that conversation with a partner who is male or a penis owner, by being able to explain this to them, that really helps a lot of times to help them understand where their partner is coming from and why they don't always initiate. Okay. So we're going to kind of jump in when it comes to the effects that we see from breast cancer treatment. So, it's not necessarily the breast cancer itself that is causing the sexual health concern, But a lot of times it's actually going to be the treatment options. We kind of talked about that. So when we think about the treatment options as either a lumpectomy or a mastectomy, right, body image comes into that a lot, right? Again, it's how we're defining us, who we are as women. And I have this conversation a lot. When women tend to get hysterectomies, they don't necessarily feel less feminine, right? It's on the inside, it's not on the outside. But when it comes to breasts and breast surgery, that can be really detrimental to that individual. That breast defines them as a woman. It's curves, it's who they are. It may be what they help to nourish their children if they decided to breastfeed. They may have enjoyment of their breast being touched, and now they have less sensitivity, not just to the breast, but to the nipples and the areolas as well. There's a lot of partner concerns that go along with it. Like, am I going to be attracted to my wife? Is this something that I'm going to have to grieve because they're having this done? And so oftentimes we don't talk to the partner about what's going on, and they do feel left out sometimes as well. So making sure that we're including everybody that's going to be a part of it, right? And because of the body image and not feeling like yourself, that's going to lower your libido. You're not going to feel attractive. You're not going to feel beautiful. You're not going to feel like yourself. So, you know, if you're feeling that way, how is your partner feeling? And that's just going to like throw your libido in the tank, and you're not going to want to participate in anything. And the other thing that I talk to, again, my patients about a lot, if we are thinking that, right, the logical steps of sex, penis and vagina intercourse, or whatever it may look like for you, is that, right, you start kissing, you start touching, that all leads to the next steps, rather than it's just a kiss. It's just hand holding. So we often avoid those interactions with our partner because we are so afraid that it's going to lead to something else that we don't necessarily want to do, or we haven't talked about it, or where should they touch me, or it's sensitive here, or it hurts. And so again, one of the things we'll talk about as far as an exercise or homework that I give my patients is just kissing exercises, getting back to the basics. When was the last time you had a really good makeout session? And a lot of people can't answer that question. And a makeout session, right? It's like that 3-4 minute like lip lock action that you had like in the backseat of your car in high school, right? And that's, you know, those are the things to recreate. You can still get in the backseat of that car. It's just your parents may not be coming after you, right? Trying to figure out where you are when you were in high school and maybe someplace you weren't supposed to be. But it's still being able to recreate that and get that fun and that innocence back that you once had. When we think about combination therapy, especially with radiation, right? Not only are we having the mastectomy now, we're actually having scar tissue that's happening. That area is starting to retract down. It may not have as much movement. So if you really enjoyed, I talk to a lot of my patients about bondage, right? And so if you really enjoyed having your hands tied and up over your head, but now you've got limited range of motion, how are you going to be able to do that? If that really was something to turn on that you wanted to do, how do I accomplish that now? And then obviously side effects. We know that radiation can create a lot of fatigue, loss of energy, just overall not feeling well. And so, right, how am I supposed to have sex or want to have a lip locking kissing session with you if I feel so crummy? And so being able to talk about when you do feel good, and, you know, if that's first thing in the morning, after you've had a really good night's sleep, after you've had your cup of coffee and you've had some breakfast, you know, that's how we can strategize to figure out when is going to be the best time for you to incorporate that intimacy. And then obviously, you know, the numbness and decreased sensitivity can happen as well. A lot of women actually derive a lot of pleasure from their breasts being touched, from them having nipple stimulation. So what we try to do, right, there's erogenous zones everywhere on your body. And what we try to do in that situation is we try to find another erogenous zone that might give you a very similar sense of pleasure. So people forget the earlobes are a really good place to create some sensitivity. Listen, you got some erectile tissue in those earlobes too. You actually have erectile tissue in your nose. So the thing about that is when you get aroused, listen, I think sex research is probably the most fun research out there. So there were researchers that actually looked at the changes in face as people were turned on and started to have arousal and stimulation. So when you looked at faces, their nose actually swelled during that time frame of that arousal time frame period. Remember when we looked at the sexual response cycle, and a lot of that is actually, so it increases your sense of smell, so you can smell your partner more, so you can get those pheromones up into the olfactory piece in your brain, so it turns on all of those good feeling chemicals and to create bonding with your partner, right? Science is awesome. So again, with that being, you can actually stimulate your nose, like with a vibrator, anything like that, or just even rubbing it, nuzzling into your partner too, can create some sensation. Again, the collarbone, if that's not causing you any problems, the lower jaw. So again, it's exploring, and we'll talk about an exercise called body mapping that I go through with my patients as well a lot of times, so we can figure out where some of those other erogenous zones might be for us to take the place of what felt so good at that breast or that nipple. If someone is going to have a prophylactic hysterectomy and have ovaries removed, that causes a whole nother slew of issues that are going on. So sometimes what can happen is when we remove that uterus and that cervix, the way that happens, it can shorten that vaginal canal. So if our partner had a longer penis or we were using some sort of device or toy that caused a little bit more depth penetration that felt good to us, we might lose that. That can also cause decreased vaginal lubrication. You've lost that cervix, which provides a lot of moisture and lubrication during sexual arousal and just by walking around. And then also some loss of genital sensation. If any of the nerves are involved, like the pelvic nerves or the pudendal nerve has been compromised, that can definitely cause loss of genital sensation as well. And obviously losing a lot of the hormones that are coming from those ovaries, then you lose a lot of the hormones that are in those vulvovaginal tissues as well. And things start to thin out. They become really dry, very uncomfortable, and they've lost a lot of that elasticity as well. This is an amazing image. So this was done by the Health Related Quality of Life study back in 2014, and they looked specifically at breast cancer. So we can see here, they have a whole circle on femininity and sexuality, right? Of all of the different things that impact, that can be impacted from breast cancer and breast cancer treatments. We also have, again, the emotional, cognitive things that are going on too, some of the other physical side effects that are going on. It's funny, they don't talk about sexual functioning too. So again, that's going to be on the genital side of things. Obviously, right, social relationships in different roles. So again, with a partner, or again, with family. If you're tired, you don't feel like you don't want to go out. Again, some social isolation may happen too. If you can't go to work, or if now you're becoming disabled, you're worried about the financial piece that's going on. So again, when we talk about biopsychosocial, the whole gamut of what's happening, that's going to be really key. A lot of times I will pull this out, and I have it printed in my office, and we'll pull it out and we'll be able to look at it and go, okay, are you feeling this way? Are you feeling that way? What's going on? What can we do to make it better? That we get a chance to really isolate all of those things and tackle them one by one to see if we can come up with a game plan to make them better. When we talk about adding chemotherapy now, that's again a whole nother ballgame. If you do decide to keep your ovaries, this might throw you into some premature menopause. If you are young enough that possibly having more children, becoming pregnant, we now have to worry about this fertility as being an option and going through the whole reproductive endocrinology side of things. And that can add a whole nother layer of stress and frustration, especially if you're trying to go through fertility treatments. And now the whole point of the intimacy interaction is your partner giving you your injections to stimulate ovaries for follicles so that you can retrieve those. So again, it's this back and forth that we see. We talked a little bit about some vaginal dryness on the slide before, but this is definitely going to happen. And I see a lot of, again, that low libido. We talked a little bit about the ovaries and the hormones that come from there. Your ovaries produce about 90% of your testosterone that you make in your body. The other 10% comes from your adrenals. And so women have 10 times more testosterone in their body than they do estrogen. Anybody know that? Did anybody know that before? Right, we don't talk about it. We think that estrogen is the hormone for women and that testosterone is the hormone for men. And that is not it at all. Again, we have lots of research that shows us and studies that have drawn levels of testosterone for women that say that, again, that testosterone is 10 times more higher. Testosterone, when we look at the cascade of sex steroids and when things start to move forward, testosterone is the precursor to estrogen. So you have to have testosterone in order for estrogen to even be in your body. And so when you lose that ovarian function, you're losing that testosterone as well as that estrogen. When that happens, again, the low libido can happen because testosterone for women gives us a little bit more libido, gives us energy. It helps with mental fog. It helps with muscle mass. It helps with digestion. It helps with sleep. So testosterone helps with so many amazing things, but yeah, we don't talk about it and it being an option. And the crappy, I'm going to say crappy a lot. The crappy piece of this is that here in the United States, we don't have an FDA approved testosterone formulation for women. What I have seen in studies, we've been studying testosterone for women when it comes to the libido piece of it versus the other awesome, amazing things that testosterone can do for women. I hear women in menopause all the time. I'm tired, I'm fatigued, I have no energy, right? So we slap on some estrogen and that helps a little bit, or maybe we have some hot flashes and that helps a little bit. But again, we're forgetting about the testosterone piece. And I'll give you a little teaser, right? I can actually use testosterone therapy in women that have had breast cancer and it's safe, right? So exciting. That's awesome. Yeah, and Juliana asked, is that something that can be taken with letrozole? Yes, absolutely can. So again, that's the amazing thing with it. I've gotten the blessings from my oncologists. But we have to make sure that we're doing it very, very safe and we use such a low level, right? So letrozole is actually, so we are blocking it and then supplementing it. Yeah, so letrozole actually, so what letrozole actually does is it blocks the conversion of testosterone to estrogen. So, but again, your body, listen, when we put you on all of these medications to wipe out anything that could possibly feed that breast cancer, again, we're thinking a lot about the estrogen. We're thinking about testosterone too. So what's happening though is that, yeah, Rebecca, you can ask your oncologist to prescribe it. You can talk to a menopause practitioner. I will say that a lot of oncologists are not familiar with testosterone. So if you are in the Charlotte area, I'm happy by all means, we can work out virtual appointments and things like that. But if you are in the Charlotte area, Aleece Kelly Jones, and I'm going to put her, so it's another Aleece. We are really good colleagues, and she deals with female sexual health too. She is with Novant Health. So she's a physician, like I said, in the Charlotte area that can definitely help you all out as well. And she can definitely prescribe that for you. Everybody's a little bit different when it comes to their cancer stories. And so again, I always like to see what your history is before we just go throwing on testosterone. And again, always want to make sure that we are talking through with the oncologist to make sure. Yeah, Juliana, go ahead. You can unmute and ask away.
Hey, thank you. So so you said that is there a testosterone for women approved in the US or not?
There is not.
There isn't. So what would it be that would be prescribed?
Yeah, so I would do a compounded testosterone for you. So,
okay.
Yeah.
Okay.
Which again is crummy because insurance doesn't cover any compounded or any compounding formulations. But typically, the compounding pharmacies that I use, anywhere between $30 and $40 a month is all that it would cost you. So we're not talking like hundreds of dollars.
Sure. But I guess I'm having trouble understanding. So if the letrozole disrupts the conversion of testosterone to estrogen, but yet a compounded, and because we don't want that in our body, correct?
Right.
But this compounded testosterone then wouldn't wouldn't turn into estrogen. Is that how it works? Okay.
Yep, it is. So, right, we are suppressing the ovaries because we know that that's where the ovaries are making estrogen. But on the other side, it also makes testosterone. So it's wiping it out completely. But remember, we do get about 10% of our testosterone that comes from those adrenals. So that letrozole is picking up that 10% that the other medications or the chemotherapy is not capturing. And so that we are trying to block the aromatization to estrogen as much as we can. But again, we're wiping. So if you wiped out 90% of your testosterone, that's a huge part of your testosterone. And so your body can't function optimally with just 10% of the testosterone. So we have to come in kind of on a backwards way and supplement that testosterone for you. Does that make sense? But then you're on letrozole, so the testosterone that I'm giving you is still blocking that conversion. So it's a little protective on you there too, that it's not converting over to estrogen.
Oh, okay. Because estrogen's the problem with ERPR positive. It's not testosterone. Correct.
Correct.
Okay.
Yes.
All right. Thank you.
You're very welcome. I'm glad you asked that question.
Yeah.
Rachel talks about getting, yes, Lupron shots, right? So when Lupron, I mean, you're coming from that hypothalamic pituitary axis, right? We're blocking everything from happening. And you're on an anastrozole, right? Which is blocking estrogen as well. So thinking that, yeah, the Lupron has stopped the testosterone production too. So what we know what happens is you have your hypothalamus, which sends that gonadotropin releasing hormone to the pituitary to send signal, to send FSH and LH to your ovaries to start producing hormones. So if we are blocking it from the tippy top so that you're not getting any kind of signals to let those ovaries to work whatsoever. And so that stops your testosterone production too, because it's suppressing those ovaries as well. Does that answer your question? Okay, if not, I'm happy to talk to you offline if we need to have a little bit more conversation about it. Does somebody else want to ask a question? Okay, cool. Pam said, okay, if tamoxifen doesn't stop testosterone conversion, would the testosterone still be safe? Yes, absolutely. Yes. So tamoxifen is working a little bit differently, but yes. And so this is the other thing too. I always monitor, would I need a referral to see the other Aleece? Most likely not. It all depends on your insurance also. So you could always reach out to your insurance company or possibly call her up directly. So do our bodies go back to your former selves after you finish chemotherapy? So again, this is kind of the crummy thing. It depends on how much chemotherapy you're having to take and how long you're having to use it. Again, everybody's cancer stories and timelines are going to be a little bit different. Most of the time, it doesn't come back. And that's the crappy piece. So if we're giving chemotherapy and it's shutting those ovaries down, sometimes those ovaries won't wake back up enough to start stimulating those hormones. But again, we're wanting to decrease the estrogen. So we don't even want those ovaries necessarily to wake up. And then we're putting medications on there to block the estrogen as well. So, this is where it gets a little tricky. And then you get all of the side effects in your body from that. So just like, we talked about vaginal dryness, because we're taking away a lot of those lovely hormones in those vulvovaginal tissues. You have testosterone in the vulva and in the vagina as well. The clitoris is a big testosterone. I see you rolling those eyes, Julian. Yeah, I know. It's like, I know. And again, they don't tell you any of this. I didn't get this in PE school. I'm super pissed. Yep. And I'm going to spread it all over the country as much as I can. So you have, I know it. So you have testosterone receptors. We're going to do a lot of hand vaginas today too. So you have testosterone receptors here at the opening. So this is the vestibule. The clitoris has testosterone receptors, and the anterior or the top part of the vaginal wall do. So, right. So it's not just estrogen, that we are, worried about you're losing. Now it's all of those hormones in that area. So when that happens, you thin out the tissues, you lose lubrication, your vaginal pH goes up. When you do that, you kill off all of the good bacteria, and you lead yourself to vaginal infections now of bad stuff. So it could be yeast, bacterial vaginosis, those types of things. When that happens too, if you happen to have genital warts or even genital herpes, it can totally flare that also, because it's impacting that nerve in that area. Because some types of chemotherapies get filtered through the kidneys and into your urine, I have seen some of my patients, at least during their treatments, that they have a lot of bladder irritation. One of the things that I help to protect that bladder is aloe vera. Aloe vera 600 milligram capsules, taking 2 capsules 3 times a day can be really helpful to protect the lining of the bladder. Now, most of the time after chemotherapy is stopped, your bladder will recover. I would say on rare occasions that doesn't necessarily happen. Again, we talked about the different types of hormone therapy. So somebody already brought up the tamoxifen, right? What tamoxifen is doing is decreasing that cell sensitivity to the estrogen. We talked about these aromatase inhibitors, so anastrozole, letrozole, right? It's disrupting that conversion from testosterone over to estrogen. And then that's just another thing on top of that that's causing, again, worsening of that vaginal dryness, lack of elasticity. So what we see in the folds in the vaginal canal are all these rugae, right? All of these ups and downs. So when something goes in it, it has a chance to expand. When we go through all of these treatments, we lose all of that, and then it gets really stiff. It doesn't want to move as much. So if we start having any type of penetration, it's not stretching. It's going to cause pain and these what we call micro tears that can be really detrimental and cause a lot of pain in those individuals. We can see what happens is a lot of the, again, another hand vagina of it narrowing down. So the vaginal opening itself is so tiny that sometimes I can't even get my pinky inserted into my patient's vagina. And so how in the world are we going to be able to get any kind of other sexual toy, penis, anything that's going to go in there? It's going to cause a lot of pain. Okay. So I'm sure we kind of already touched on it, but so again, right, 85% of women that go through breast cancer treatments have a sexual health concern. We know this already to begin with. So when we start talking about what kind of care do we want to provide, as medical providers, we are so problem focused, right? Versus prevention. Now, obviously, with breast cancer, we want to prevent it. We've got mammograms, but we know that this is going to happen to a lot of our patients. So why are we not having the conversation before it happens, right? Again, we're so focused on the cancer, getting you better. What are we going to do to maximize, again, your survival? But again, we need to be having those conversations with our patients way ahead of time. We don't talk to our patients about preventing a heart attack after they've already had their first heart attack. We want to talk about it before it. So again, the pelvis and those vulvovaginal tissues are no different. So again, here's what we can do. So remember we talked about the libido side of things. Obviously, it's a mixed bag. It's not just the physiological stuff that's happening with your body with lowering your hormones. It's a psychological impact too. So there's a lot of balance. So that's the unique thing about me of being a sex counselor is I get to do both of those. I get to say, this sucks. But we have lots of things that we can do to actually make it better. And I have that prescription right to be able to say, we can try this, we can do that. On the hormonal replacement options, I know probably a lot of you have heard when it comes to, again, hormones, is that we can't really do any estrogen. Right. And again, that thought is that estrogen is what women have and testosterone is what men have. But here is that thing where it comes in with testosterone is that that's an option. When we think about replacement on a male side, you can do a topical gel that has 50 milligrams of testosterone that men would use once a day. Women only need about 1/10 of the dose of what we see on the male side of things. So you're talking 5 milligrams per day. But for my breast cancer patients, I start even lower than that. And we start at 1.25 milligrams of testosterone on a daily basis. I just want to start where you're at, just to see if I can get you just a little bit of testosterone in your body to help make a difference. And then we titrate up just a little bit. I do routine labs. So I'm checking your testosterone, I'm checking your estrogen levels to make sure that your serum estrogen levels are not rising at all. If that's something that we start to see, then that's a conversation that you and I need to have, or the oncologist needs to have too. You can also do DHEA. DHEA is the hormone precursor to estrogen and testosterone. So we're looking, again, we're backing up our cascade of those sex steroid hormones being developed in your body. So DHEA, again, and this is not FDA approved, so this has to be all compounded, but we can definitely do a little bit of topical DHEA to help out with those too. Again, we have to be a little bit more cautious with DHEA because, again, we know for sure that can be converted over to estrogen a little more likely than just testosterone alone. FDA approved medications for low libido and decreased desire. Aleece and Addyi have come out on the market. These are non-hormonal types of medication. So Aleece came out in 2018. I can't remember off the top of my head now which one that came out. This is a sub-Q injectable that you can use. You inject it about 45 minutes before you know that you're going to be engaging in some sort of sexual intimacy. The thing about Aleece is that if you have uncontrolled high blood pressure, we have to make sure that we talk to your cardiologist before. What happens is you have this almost transient sympathetic response system that happens. And so you get your heart races a little bit more, your blood pressure goes up. So again, we have to caution with that. But I've used Addyi. Addyi came out in 2015. Addyi is, I think, a great, wonderful medication. It is the first medication that came out for women's low libido in 2015. When Viagra came out in 1995, does anybody know how many prescriptions were written in the first month that Viagra came out? 1 million. 1 million prescriptions were written in that first month, right? How many prescriptions of Addyi were prescribed in the first year? 100. That's it. We have a drug that makes better women's low libido, and it's non-hormonal. It works in the prefrontal cortex of the brain. It was researched for depression to begin with, but what happened is, again, just like everything, there was a side effect that women reported that they were having better sexual satisfaction. They had more desire, and they thought, oh, we need to bank on this one and start researching it. So that's when they started researching Addyi as more of a low libido for women. This drug was started to be researched in phase 3 clinical trials when I was in PA school. I graduated in 2011, and it wasn't until 2015 that it finally got approved. And it wasn't until recently in 2019 where we really started to see Addyi pick up. So what Addyi does, it works about 70% of my patients who start to take it. Viagra and Cialis only work about 50% of the time. So, right, we have a much higher efficacy medication, but yet we're still not writing it. And the side effect to this is it makes you sleepy. So guess what? They are researching it right now for sleep. It works great. And it's not habit forming. Like, what in the world? So again, it's a medication that doesn't cause a lot of problems. It does work on the central nervous system, right? So we want to make sure that if somebody is going to be taking alcohol or drinking alcohol, that they don't take the medication within 2 hours of listen, Rebecca, everybody needs Addyi. I want to put it in the waters because I think that it works so well for my patients. And the cool thing about Addyi too is it has a compounding effect. So it's not that you get to like a plateaued place. They're even researching it now for women taking it at 6 months and 12 months, and they're seeing continued improvement on this medication. So it's not like it stops working. So, I mean, how amazing is that? So again, it works in that prefrontal cortex. What happens for women that have low libido is a lot of it is their inhibition is really high and their excitation is really low. So what's happening with Addyi is we switch it. Okay, we lower that inhibition and we raise that excitation. What a lot of my female patients have said is that they've been sitting doing something and all of a sudden they're like thinking about sex. They're a little turned on and they're going, oh my goodness, this actually is working. It's super subtle, but it's so powerful. I had one patient too that said that they were doing something like at the kitchen table or something. They looked over and their partner was doing something in the living room. I can't remember what it was. And they were like, I wanted to jump his bones. I was so turned on. And so again, we talked about that spontaneous piece of desire, but it even helps with that more responsive. So some women, again, will kind of shy away if their partner makes an advance. But what this one does too is they've become much more receptive to those advances. So again, I'm not saying that Addyi is like the wonder drug, but it works better than Viagra. It has less side effects than Viagra. So again, it's an amazing drug and it's non-hormonal, right? So again, we know that that's a safe medication then for our breast cancer patients. And then obviously I'm very big with collaborative care. So referring to like a sex therapist or a sex counselor, I think is really important to be able to utilize all of those individuals to help out with the team. Okay, so dryness, right? This is gonna happen too. Obviously, we want to make sure that we're avoiding any kind of glycerins, parabens, or fragrances. I will tell you that KY Jelly and Astroglide are not my favorites in any of those directs. They have all of those things in it. So be thinking of other options for that. Uberlube is one of my favorites. It's a silicone-based lubricant. You can order it off Amazon. If you have Prime, it'll be to you in 2 days. You can go to uberlube.com. I have those websites at the end of the presentation too. But that's going to be more of a lubricant that you would use during the time of sexual play. And you're not just going to put that into, yes, silicone is totally safe for your body. Great question, Laura. So we don't have to necessarily worry about it getting absorbed into your system. These products have been studied and it doesn't get absorbed. The cool thing about silicone is it acts as this protectant. So again, if this is the vagina, it sits on top of it. So it has this much more gliding kind of property versus getting absorbed into the vagina. And you're saying, okay, well, Aleece, it's in my vagina now. How does it get out? Well, that's the cool thing. Your vagina is a self-cleaning oven and it will eventually work its way out and not get absorbed into your system. So again, the vagina is super cool. Moisturizers are going to be something that you could apply on a daily basis. Something that has hyaluronic acid in it is beautiful and fabulous, and it helps to really increase the richness of moisture in those tissues. So Reverie is a product by Bonafide, and it has hyaluronic acid in it, and it's a vaginal suppository. You can pop it in on a daily basis if you wanted to. Again, no hormones in it. So then when we start talking about hormone types of therapy, right, because sometimes moisturizers and lubricants just don't do it. We have to replenish the hormones that are in that area. So remember we talked about DHEA, that you could like rub on your body to be able to get absorbed systemically. But we have DHEA vaginal suppositories that are called Intrarosa that you can place into the vagina and they stay there. So remember, DHEA is the precursor to estrogen and testosterone. There is no black box warning on this because it doesn't contain estrogen. So we do know that this is definitely a safe product for our patients that have breast cancer, either going through breast cancer treatments or afterwards. Again, it's a suppository that you can place every night. There's only 2 ingredients in it. So the DHEA, and then it comes in a yam base. We know that yam has moisturizing properties. So when they were studying this medication, the placebo group also got some benefit because the yam has those moisturizing properties to it. So now you've got both on in that product, and it works really, really well. You can also do testosterone. This is a compounded medication that you can place directly into the vagina and on those vulval tissues as well. That testosterone is going to convert over to testosterone and again, stay in those genital tissues. Very little, if any, gets absorbed systemically. And I tell people all the time, get a pelvic floor physical therapist. So, and we'll talk about the reason for that being is this cycle of pain. So when your body has pain, it doesn't like it, right? It isn't something that it wants to do. It's going to think about what gave me that pain. It's going to think back to those events and go, oh, it was when we tried to have sex. okay, I don't want to do that again. So it's going to be super protective of your body. So what happens is your body then anticipates that pain if you get into that similar situation, right? So wait, kissing led to sex, sex led to pain. I don't want to even do kissing, right? So that's why you start to avoid even those little kind of intimacy acts that you might engage with your partner. So your body anticipates that pain, okay? What happens is those pelvic floor muscles lock up. They're not, listen, they are the moat around your castle and they're not letting anything in. So they tighten up and they go, nope, we're not going to do this. You still try to engage in that sexual play, and that tightness now causes more pain. That pain reinforces that reflex response, right? And your body braces even more. And it's this vicious cycle that happens all the time. So when you have these tight pelvic floor muscles, I can throw all of that DHEA that I want to into those vulvovaginal tissues, but it's not going to decrease the muscle tension in that area. So a pelvic floor physical therapist can help you do what's called down training and down regulating of those pelvic floor muscles, either through some trigger point release, using vaginal dilators. Those things can be really helpful as well. What about reaching orgasm? Okay, so this is another thing. Either I hear that it's much more difficult to even get to reaching orgasm, or their fireworks on 4th of July are now the sparkler that they've got in their backyard. So they're not, the intensity of that orgasm is not as good as it once was either. But if we've lost testosterone to the clitoris, we've lost blood flow to those clitoral tissues, those nerves aren't working as well either. So what we can do is I can actually compound sildenafil or tadalafil, which is Viagra and Cialis, and I can put that into a cream that you can apply directly to those genital tissues to help bring blood flow into that area. You can also take it orally. Women can take Viagra and Cialis too. We just don't have to take as much of it. And when they studied it for women, they studied it for libido. Does Viagra cause libido? It causes blood flow. So they didn't get a chance to really look at the clitoral blood flow. Those are some things that I can do in my office too. I have an ultrasound machine, and we can look at clitoral blood flow before and after. I have seen in a lot of my female patients, even after hysterectomy, and I've done them the clitoral blood flows before and after hysterectomy, and that blood flow actually decreases. I've seen it decreases in half. And so that's a lot of change that's happening into that area. And again, nobody told them that that could possibly be something. Oxytocin is one of the major neurochemicals in your brain that gets released during orgasm. And the more that you can have in your body at the time that you're having arousal and reaching that threshold, the more intense and the easier it is for you to get to orgasm. So that comes in what we call a little troche or a little tablet that dissolves in your mouth, or there's a nasal spray that you can use too. Typically, that's something you could do on a daily basis. Again, to build it up in your system, or something that you could do about 30 minutes prior to sexual activity. And then again, a pelvic floor physical therapist can definitely be something to help you out too, right? If your muscles are all tight and you can't get the blood flow to the clitoris, then that could be an issue too. So that pelvic PT can help decrease that tension that's in those muscles as well. How about loss of sensation? So you're losing a lot of the nerve connection. You need nerve connection in your genitals to send that signal to your brain to say, okay, send the signal back for arousal to happen, for again, orgasm to happen. And so for that to be the case, a vibrator is a great tool to be able to use. We use vibration in a lot of different areas. So my pelvic PT has what's called a hypervolt, which it almost looks like this big, construction device. It's got a handle on it and it has an attachment to it, and it goes up and down really fast so that you can put it on the shoulders to work out muscles, but it causes some vibration. So what vibration is doing is bringing blood flow. It's helping those nerve sensitivities. We know that vibration helps with headaches, with muscle tension. So vibration can help in the pelvic floor as well, not just to decrease the pelvic floor muscle tension, but to bring blood flow and nerve sensitivity in that area also. So adding that, again, can be really, really helpful. We can also talk about some neuropathic types of medications. So gabapentin is one that a lot of times you can compound into a cream also and be able to apply it to the genitals also. And then physical therapy is going to help with that as well. So when we start bringing in the sex counseling piece of it, this is this added layer that I get to help my patients do. So what does sex counseling entail? So we talk a lot about self-affirmations. I have my patients write on sticky notes. I am beautiful. I am strong. I am worthy. Anything that's going to resonate with them. And I have them put it in their wallet, or I have them put it in the visor in their car. I have it put them on their bathroom mirror, any place that they're going to see it, so that we're talking about it. And this is on a daily basis. Even if it's something that you wanted to journal every day, some self-affirmations, again, we know that positive thinking can make positive changes in your life. So again, it may sound really silly, but it works really well. Mindfulness is another great one, especially to help you be more present and be in the moment. We get so caught up in what's happening next that we forget to see what's happening right in front of us. So mindfulness can be, you close your eyes, you do some deep breathing, you think about the ocean and the waves going in and out. There are tons of apps on your phone that can talk to you about meditation. There's a book, excuse me, that I recommend called, oh my goodness, I have it on the end on here too. Better Sex Through Mindfulness by Lori Brotto. And so she talks a lot about how that mindfulness can, again, bring you into the present moment, and how that then you can carry that over to your sexual encounters to improve those as well. Refocus goals. I take sex off the table for a lot of my patients to help take the pressure off, right? It's not about intercourse. It's about having that connection, having that pleasure with your partner again, having that pleasure with yourself. So if the goal is always intercourse, we know that there's lots of these things that are roadblocks for us to get there. So we got to be able to take that off the table, not forever, but take it off the table just for a little bit, so that our bodies can consciously take a breath and not feel so much of that stress that goes along with that. Body movement. I encourage my patients all the time. Body movement's really great to what we call complete the stress cycle. So, you get stressed, you get stuck in your body, and you cry, or you exercise, or you move your body to move that stress out of where it's stuck in your body, so that you can feel more energized and more alive. So body movement, dance classes, hip hop. I think I was a backup dancer for J-Lo in a different life because I love dance and it's so much fun. So just to move. Listen, I have been known to turn on a favorite song for a patient, and in the middle of our appointment, we're going to stand up and we're going to dance. Because if this is the only time that in your day that you have to dance, we're going to do it. So body movement can be so important. We talked a little bit about scheduling intimacy as well. Again, because then we can prep, right? We can know, okay, I want to make sure I get a good night's sleep, that I want to make sure that I have enough food in my belly. I've been hydrated enough, that the kids aren't around. Again, so you're doing all of those things to help with it. I talked about my kissing and touching exercises. A 2-minute kiss every day is so powerful. It takes all of those nerve endings from your lips and sends signals to the limbic system in your brain. The limbic system in your brain sends testosterone and dopamine and oxytocin. So all of those good feeling chemicals to help boost your energy. And I wish I was everywhere, Rebecca. But again, all of those types of things that you can do. So again, kissing, right? 2 seconds or 2 minutes is a long time if you haven't kissed for so many of that. So I usually start with like 15 seconds, and then we build up to 30 and then 45. So that's how we kind of build it up. We do have a lot of studies that show too that the frequency of touch with your partner is really important also. So even if it's when you walk by, if you just graze their back, touch their butt, I don't care, whatever you want to do, their shoulder, you want to hand hold, you want to sit next to them on the couch, right? A lot of times people have 2 recliners. and in the living room, and they sit separately. So climb up in their lap, buy a love seat, buy a couch, anything like that that's going to put you closer together more consistently and frequently. The body mapping can be really good. Again, I draw just like a little, gingerbread person, and we say, okay, what areas on your body feel safe for somebody to touch? What are off limits? And then we talk about how am I going to talk to my partner about this. And then we go through it every couple of months. Is your body mapped the same? Do we need to change anything on it? Is a place on your body feeling more safe for you to be able to touch? You can do hand over hand exercises too. So if this was your hand, and then you have your partner's hand over top. So what you can do is you would move your hand to the places that feel good, right? It feels safe because it's your hand. When that feels safe enough, we switch. We put your partner's hand on the bottom, and you put your hand on top and help guide them until it gets to a point where you feel safe enough that you can let them touch that shoulder. Use of toys, vibrators and all sorts of things. I mean, there's just a whole gamut of things that you can use. I do a question and answer sessions. So these are fun where you can write a question down for your partner, place it into the question jar, and you can schedule a time to be able to have those conversations with your partner. Sensate Focus is another exercise that involves touch, and it's usually over like a 6 to 12 week time frame. There's certain steps that go along with it, but again, it helps to take sex off the table and relearn touch and relearn communication with you and your partner. And then, like I said, lots of books, websites, and referrals. So again, here's like the whole thing, right? There's so many circles, there's so many things going on all at the same time, and they're all weaved together. They're all interconnected. So it's not just the one thing that's going on. Again, this is really affecting you head to toe. With the 2-minute kiss, yes, Rachel, it would still work with that Lupron, because again, that hypothalamus and that pituitary are nowhere near overlapped in the same vicinity with your limbic system. So again, it would still work there for sure. Great question. Here are all those resources that I talked about. So NAMS, which is the North American Menopause Society. I failed to say I'm a certified menopause practitioner. As well through the North American Menopause Society. ISWISH is great. That's the International Society for the Study of Women's Sexual Health. You can go on both of those websites and locate any professionals that again are in this area. ASECT is the American Association of Sexuality Educators, Counselors, and Therapists. This is who I'm certified with as a sex counselor. Again, you can go to their website and look up providers in your area. If you're looking for a physical therapist, more information, SMSNA is the Sexual Medicine Society of North America. And then here are 4 great books. So we talked about Come As You Are, Sex Matters for Women, which is by Sally Foley. Look, I got all these on my bookshelves. Yeah, Sex Matters for Women, Intimacy After Breast Cancer. That one may be at my office. That's another great one. The Better Sex Through Mindfulness that we talked about too. And then here are the websites that you can go to also. So Uberlube is that lubricant, that silicone lubricant. Crave, Dame, and Intimate Rose are all of the safe places for you to go to buy vibrators, toys, vaginal dilators, all of those types of things. So again, it's really important too that products are what we call body safe. If you go to a adult toy store and you opened up the plastic cover for a toy and it smells like you just opened up a shower curtain, that means it's emitting these gaseous chemicals, and we don't want that in your body. I know, I love that face, Juliana. Yeah, like is it yuck? Why would I want that in there? So yes, we want to make sure that these are all body safe. I like Crave. Crave actually has stainless steel types of vibrators. So they feel a little bit heavy, but they warm up. So that can be a really good sensation that you can feel too. Stainless steel is going to be safe for the silicone. Dame has a whole bunch of silicone vibrators. I love Dame because they have actually like a fingertip vibrator. So it attaches onto the end of your fingertips. So again, remember we were talking about finding those erogenous zones. So now you can again, place it to your nose. You can place it to your earlobes, all of those different areas. It doesn't have to just go straight to those genitals. And I tell people too, right? You have all of these fascial structures that are attached to the genitals. So the pubic bone is what helps to support that clitoris in place. So you can actually don't have to go right to the clitoris to stimulate, use that vibration. You can put it on the pubic bone, a little above it. Some people like their inner thighs. So again, this is what we talk about with even body mapping the genitals of what can feel good and what maybe you have too much of sensitivity on the clitoris. So again, that can happen also. So we just got to navigate what works the best for you and your body. That was a lot of information. Whew. I could talk about this all day, all month, all year. Oh, Betty, thank you for that. So she said, I'm just so sorry that every breast cancer patient has not had the opportunity to listen to you tonight. Well, it's being recorded. So they have the opportunity to do that. You've got my information there also. So that's my website, and that info at Fosnight Center is a great way to get a hold of me if you have other questions. Again, I know that I'm not in Charlotte, but again, the beauty of the virtual age, thanks to COVID, is that we can actually do some virtual appointments. I do take commercial insurances, Blue Cross Blue Shield, Aetna, United, MedCost, TRICARE. I know I'm missing one. We don't take Medicare or Medicaid, but we do have adjusted rates for those individuals that have that, because I want to make sure that access to care is happening. So yeah, and then I gave you a name of my colleague that's in Charlotte too. So Aleece Kelly Jones. Juliet, yeah, what is a good way to speak with my husband about actual intimacy and closeness, not just sex? So you blame me and you say, I just listened to Aleece talk for the past hour and a half. And one of the things that she said is that, yes, Rebecca, Blue Cross Blue Shield, I take. And you just say, I learned all about my body tensing and everything else, so that we need to go back to the basics in order to, that's foundations, right? We have to do that with everything in life. We can't just give somebody their driver's license and expect them to go drive on the, 4-lane highway. We've got to be able to work our way up there. And that's what you have to do with your body again. So being able to sit down and schedule some time with your husband and say, I really have something important to talk to you about. But this is where having a counselor or a therapist that can help, that sees couples, that understands grief and loss on a breast cancer side of things. We do have a sex therapist that deals again with with loss, grief and loss. And she loves helping out our breast cancer patients too. And she works with couples. But again, I'm happy to do that. But just saying, I need to start back to the basics. And that for me, what my body reads right now is connection. And what that means for me is I need to be held. I need to be kissed. I want to be kissed, not on my lips, but I want to be kissed on my shoulder or my hand or my arm or my inner thigh. And again, just saying, for right now, if sometimes taking sex off the table is really difficult for partners to hear, especially again, penis owners, right? They're spontaneous. They want that. And again, they've been programmed to think that they need it. And so it's just setting some time aside to make sure that's what you focus on, and that you're not going to be interrupted, and that you can have just an honest conversation about this is what I need. And if we can get the intimacy and connection, my body is going to be more receptive for penetrative sex to happen. So and that's what guys forget, is that there's a lot more prep and preparation for women, and that foreplay happens immediately after a sexual encounter happens to the start of the first one. So if they want to make sure that you're turned on and you're not thinking about other things, the trash has to be taken out. The dishes have to be put away. The laundry has to be done. The vacuuming. So all of those certain things, right? It's the fact that they sent you a text and said, hey, I was thinking about you today. All of those things start to plant, again, those little seeds in your brain from the time that the last sexual encounter happened into the next one. So, they have to be a little bit more conscious and make an effort to do those types of things. But
I'm sorry. Oh, I've said that to my husband for years. And now that, I've had breast cancer, I've said it. I'm like, look, I'm on this medicine that makes me really dull and boring, and I'm not interested. It doesn't mean I don't love you. So now it's funny because I didn't tell him what I was listening to tonight because I don't want him to bug me. And that's what's going to happen. It's like, the minute you say that, oh, wow, what are you doing? And it's just like, oh my God, just leave me alone for a little bit. But you're right. It's, like when we go to bed at night, I just want to talk a little bit. Let's recap the day and hold my hand. And he's totally out of it. He's tired. And I am too, but I guess we're just on a different schedule in that respect, even though I'm up before him and I'm still working and he's retired. But let's just run through the day. And then that makes me feel that much closer to you. And I love you. And who knows what'll happen tomorrow. But it's just so funny. But I'm gonna try some of these things here and think about it. And we'll see what happens.
The other thing that you all can do together. So even though this book, Come As You Are, is for women, it is a great book to go through and read together with your partner, because there's exercises and handouts and things that you can do in here. So she talks a lot about what are accelerators and brakes. So again, what are the things that turn you on and what are the things that turn you off? So if you do that together and then you talk about it, he's going to be able to say, oh, your accelerator is the fact that there's an empty dishwasher in the other room. And so that's going to be like, oh, I didn't even think about it. So, and then for him, his accelerator may be the fact that you all are having a conversation in bed, and that's what turns him on. So again, that helps both partners on that communication side of things to say, okay, what are your likes? What are your dislikes? What are your likes? What are your dislikes? And where are there overlaps? There may be something that you all do and you're filling this worksheet out and you're like, oh, I had no idea you like that. I like that too. And even though you've been married for umpteen amount of years, I've been married for 13 years to my high school sweetheart. So we've been together for 20. And so there's still things that we don't know about each other, or that just haven't come up, or that we haven't talked about. And that's the other thing too, is thinking about, again, it's that timing, right? So he's tired, he's in bed, you're trying to have a conversation with him. So that might be something that you push back maybe 30, 40 minutes before you guys get in bed, that okay, we're going to meet on the couch at 8:30 or whatever it is, so we can recap the day. So you're sitting up, he's sitting up, the TV's not on, the cell phones are in the other place. And that feels like a really good time for both of you all to recap of what's going on and what expectations are for tomorrow. And you could be, looking at one another, not across from the table, holding hands, doing some sort of embracing. That helps again for that connection, but it's only that. It's not leading to sex. It's not, that's what it is. It's just that connection. Again, it's that seed that we're planting and help watering your garden so that it'll start to grow and that things will feel better and you'll feel safer and more connected with your partner when sexual intimacy actually happens. Is that helpful? Kind of, I know. Listen, it's easier said than done. I totally get it and that sort of thing.
Yes, it is. But thank you very much. Thank you.